Hello everyone. Before we start, make sure to like and subscribe to the channel and leave a comment with where you're from and what time you're watching. That way, YouTube will keep showing you stories just like this one. Now, let's begin. I've been an ear doctor for 15 years. Last month, a patient died on my table for 23 minutes. When we brought him back, he told me exactly what I whispered to my colleague in the break room while he was dead. There's no medical explanation for what he knew. I'm an emergency room physician at St. Catherine's Regional Medical Center in Portland, Oregon. Or at least I was until I submitted my resignation 3 weeks ago. You can call me Dr. Sarah Mitchell if you want, though most people in the ER just called me Doc during my 15 years there. I've seen everything you can imagine in emergency medicine: car accidents, heart attacks, overdoses, gunshot wounds, and every kind of trauma the human body can endure. But what I'm about to tell you about is the one case that made me question everything I thought I knew about consciousness, death, and what happens when we cross that final threshold. St. Catherine's is a level 1 trauma center serving the greater Portland metropolitan area and parts of southwestern Washington. It's a state-of-the-art facility built in 2008 with a 32-bed emergency department that handles about 65,000 patients per year. During my time there, I worked primarily day shifts, 7 a.m. to 7 p.m., because I preferred the controlled chaos and the variety of cases we typically saw during daylight hours. Day shifts in emergency medicine are unpredictable in their own way. You might have 3 cardiac arrests in an hour followed by 6 hours of routine complaints, or you might be managing a multi-casualty incident that tests every system in the hospital. The day of November 8, 2024 was shaping up to be one of the busier ones. It was a Friday, which usually meant we'd see our share of workplace accidents, early weekend injuries, and the occasional overdose from people starting their celebrations too early. The weather was clear and cold, the kind of Pacific Northwest autumn day that brings out both the best and worst in people. I had been on shift since 7 a.m., and by 2:30 p.m., we had already seen 47 patients: a construction worker with a nail through his hand, a college student with alcohol poisoning from a fraternity event, and an elderly woman with chest pain that turned out to be a massive heart attack requiring immediate catheterization. I was reviewing lab results in the physician's workstation when my pager went off at 2:47 p.m. The message was from our charge nurse, Linda Rodriguez, who had been working the ER for almost 25 years and was known for her ability to assess patient acuity with just a glance. The page simply said, "Incoming code blue, ETA 3 minutes, 43-year-old male, cardiac arrest." I made my way to Trauma Bay 2 where Linda was already setting up the crash cart with 2 other nurses, Jennifer Walsh and Michael Chen. The paramedics had called ahead with preliminary information. Adult male, 43 years old, found unconscious at his workplace by co-workers. The patient had collapsed suddenly during a meeting, showed no pulse, and was currently receiving CPR from the paramedic team. Initial rhythm was ventricular fibrillation, and they had already delivered 2 shocks with no response. "What's the downtime been so far?" I asked Linda as we prepared the defibrillator and emergency medications. Co-workers started CPR within 2 minutes of collapse. Paramedics arrived 8 minutes later. Total downtime is now approaching 15 minutes with continuous chest compressions. The ambulance arrived at 2:50 p.m., and the paramedics wheeled in a patient who immediately struck me as unusual, not because of his condition, but because of how ordinary he appeared. The man looked to be in his early 40s with brown hair and the paled, almost gray complexion typical of someone in cardiac arrest. He was wearing a business suit with a blue tie, dress shoes, and a wedding ring. Everything about him suggested a normal businessman who had simply collapsed without warning. "What do we know about the circumstances?" I asked the lead paramedic, Tom Bradley, who I had worked with dozens of times over the years. "Patient is Marcus Williams, 43 years old, insurance adjuster. He was in a conference room meeting when he suddenly grabbed his chest and collapsed. No known medical history according to co-workers. No medications. No allergies. Wife is en route to the hospital." I began directing the resuscitation effort while the nurses worked to get Marcus connected to our monitors and 4 access established. His heart rhythm showed ventricular fibrillation, a chaotic electrical pattern that prevents the heart from pumping effectively. We immediately delivered another shock with the defibrillator, but there was no change in rhythm. I ordered epinephrine and amiodarone, standard medications for cardiac arrest. While we continued chest compressions, the resuscitation continued for another 8 minutes with no response. We delivered 6 more shocks, administered multiple rounds of medications, and maintained continuous chest compressions and ventilation. But Marcus Williams remained in ventricular fibrillation, his heart refusing to return to a normal rhythm. At 3:10 p.m., after 23 minutes of aggressive resuscitation efforts, I made the decision that every emergency physician dreads. "I'm calling time of death," I announced to the team. Time of death, 3:10 p.m. The room fell silent except for the steady beeping of the flatline on the monitor. Linda began preparing for the post-mortem procedures while Jennifer called the organ donation coordinator. Michael started gathering Marcus's personal effects. It was a routine that we had performed hundreds of times. The systematic transition from life-saving efforts to death management protocols. I was removing my gloves and preparing to speak with Marcus's wife, who had just arrived in the waiting room, when something happened that defied every principle of medicine I had learned during my training and career. At exactly 3:12 p.m., 2 minutes after I had declared him dead, Marcus Williams gasped. It wasn't the agonal breathing we sometimes see in the minutes following death. It was a deep, purposeful inhalation followed by a normal respiratory effort. Linda looked at the monitor and her eyes widened. The flatline had suddenly changed to a normal sinus rhythm with a heart rate of 78 beats per minute and a blood pressure of 120/80. "Dr. Mitchell," Linda called out, her voice tight with disbelief. "He's back." I rushed back to the bedside and began assessing Marcus. His pupils were equal and reactive to light. His skin color was improving rapidly from the gray pallor of death to a normal pink hue. Most remarkably, he was awake and alert, looking around the trauma bay with obvious confusion but clear consciousness. "Where am I?" Marcus asked, his voice clear and strong despite having been dead just moments earlier. "You're in the emergency room at St. Catherine's Hospital," I replied, checking his pulse manually to confirm what the monitors were showing. "You had a cardiac arrest, but you're stable now. How are you feeling?" Marcus thought for a moment, then looked directly at me with an expression that I can only describe as eerily knowing. "Dr. Mitchell, why were you so upset about your daughter's recital when you were talking to Dr. Peterson in the break room?" I felt the blood drain from my face. During Marcus's resuscitation, around the 15-minute mark, I had stepped away briefly to speak with Dr. James Peterson, our cardiothoracic surgeon, about a different patient. In that conversation, which had taken place in the physician break room down the hall from the trauma bay, I had mentioned my frustration about missing my daughter Emma's piano recital the previous evening because of a late case. It was a personal detail I had shared with a colleague during a private moment while Marcus Williams was clinically dead. "How do you know about that conversation?" I asked, my voice barely above a whisper. Marcus smiled, but it wasn't the confused smile of someone emerging from unconsciousness. It was the knowing smile of someone who had access to information he shouldn't possess. "I heard you, Dr. Mitchell. I heard everything that happened while I was away." Over the next hour, I conducted what would become the most extraordinary and disturbing medical examination of my entire career. Marcus's cardiac function appeared to be completely normal despite having just experienced a 23-minute cardiac arrest. His neurological function was intact, showing no signs of the brain damage that typically occurs after prolonged periods without oxygen. His laboratory values were normal, his ECG showed no evidence of heart attack, and his chest X-ray was clear. But what truly unsettled me was Marcus's detailed knowledge of events that had occurred throughout the hospital while he was dead. He knew that the nurse in room 5 had received a phone call about her mother's cancer diagnosis. He knew that Dr. Peterson had spilled coffee on his shirt in the break room. He knew that Linda had helped a patient in the waiting room who was having an anxiety attack. Most disturbing of all, he knew personal details about the staff that he had no way of knowing. "The security guard at the front desk is worried about his son's drug problem," Marcus told me matter-of-factly. "And the woman in the billing office is having an affair with someone from radiology." I had no way to verify these claims immediately, but something about Marcus's certainty made me deeply uncomfortable. There was an quality to his demeanor that reminded me of patients experiencing certain types of psychosis. except that he showed no other signs of mental illness or confusion. "Marcus, what do you remember about your experience during the cardiac arrest?" I asked. He was quiet for several minutes, his eyes closed as if he were accessing distant memories. When he opened them, his expression had changed to something I can only describe as profound sadness mixed with an almost transcendent peace. "I remember floating above my body," he said slowly. "I could see everything that was happening in this room. I watched you and the nurses working on me. I could see the monitors, the medications you were giving me, the expressions on everyone's faces when you realized I wasn't responding." This description wasn't unusual. Many patients who survive cardiac arrest report out-of-body experiences during their clinical death. What made Marcus's account different was the level of specific detail he provided about events that had occurred outside the trauma bay. "But I wasn't limited to this room," Marcus continued. "I could move around the hospital. I followed you when you went to talk to Dr. Peterson. I watched the nurse in room 5 cry when she got the phone call about her mother. I saw things happening on other floors, in other departments. It was like I could be everywhere at once." I found myself caught between medical skepticism and the undeniable fact that Marcus knew things he couldn't possibly know. I decided to test his claims by asking him about events I could verify. "You mentioned Dr. Peterson spilling coffee. What exactly happened?" "He was pouring coffee from the pot in the break room when his pager went off. The sound startled him and he jerked his arm, spilling coffee down the front of his blue scrubs. He said damn and used paper towels to clean it up. But there's still a stain near the pocket." I called Dr. Peterson to the trauma bay and asked him about the coffee incident. His expression changed from curiosity to bewilderment as he confirmed that everything Marcus had described was accurate, down to the color of his scrubs and the location of the stain. "How does he know that?" Dr. Peterson asked me privately. "I've never seen this patient before in my life." I didn't have an answer for him, just as I didn't have answers for any of the impossible things Marcus Williams was telling me. But I continued my investigation, both as a physician trying to understand a medical anomaly and as a human being confronting something that challenged my fundamental understanding of reality. Marcus's knowledge extended beyond the hospital. He described conversations between his co-workers that had taken place after his collapse, details about the paramedics' personal lives that he couldn't have known, and even events happening in other parts of the city during his 23 minutes of clinical death. "The woman in the red car at the intersection of 5th and Morrison is about to rear-end the blue truck in front of her," Marcus said suddenly, looking at the clock on the wall. "It's happening right now." I was skeptical, but something compelled me to call the traffic department. 20 minutes later, they confirmed that a collision matching Marcus's exact description had occurred at 3:15 p.m., just 3 minutes after he had been resuscitated. As the day progressed, I found myself documenting every claim Marcus made and systematically verifying the information he provided. In every case where I could confirm his statements, they proved to be accurate. He knew about personnel changes that had been discussed in closed meetings, medical cases being handled in other departments, and personal situations involving staff members he had never met. The most chilling moment came when Marcus looked directly at me and said, "Dr. Mitchell, you're going to quit your job because of this case. You're going to spend weeks researching near-death experiences and consciousness, but you'll never find a satisfactory explanation for what happened here today. The uncertainty is going to affect your ability to practice medicine because you'll start questioning everything you thought you knew about life and death." His prediction was delivered with the same matter-of-fact tone he had used for everything else, but there was something prophetic about it that made my skin crawl. At that moment, I was confident in my career and had no intention of leaving emergency medicine. But Marcus spoke as if he were describing an inevitable future rather than making a guess about my potential reactions. I kept Marcus under observation for the next 72 hours. Running every test available to try to understand what had happened to him. His cardiac function remained normal, showing no evidence of the heart attack that should have killed him. His brain MRI was completely normal, with no signs of the hypoxic injury that typically results from prolonged cardiac arrest. Blood tests revealed no metabolic abnormalities, no drug use, and no underlying medical conditions that could explain his collapse. Most puzzling of all, Marcus's electroencephalogram, which measures brain activity, showed patterns that the neurologist described as unlike anything I've seen in 30 years of practice. The brain waves suggested a level of consciousness and neural connectivity that appeared to be enhanced rather than diminished by his experience of clinical death. During those 3 days, Marcus continued to demonstrate knowledge of events occurring throughout the hospital and beyond. He predicted which patients would arrive in the emergency department before the ambulances were dispatched. He knew about personal conversations between staff members in private areas of the hospital. He even provided details about news events that hadn't yet been reported on television or in newspapers. "Marcus, how are you able to know these things?" I asked him on his second day in the hospital. He considered the question carefully before responding. "I don't think I ever really came back, Dr. Mitchell. I think part of me is still out there, still connected to that state I was in during those 23 minutes. It's like I have access to information that exists outside the normal boundaries of time and space." It was an explanation that defied everything I knew about neuroscience and consciousness, but I couldn't argue with the consistent accuracy of Marcus's impossible knowledge. I consulted with colleagues at other hospitals, researched near-death experience literature, and even contacted researchers who specialized in consciousness studies. None of them could provide a framework for understanding what I was witnessing. On Marcus's third day in the hospital, something changed. He woke up that morning with a confused expression and asked me where he was and how he had gotten there. When I questioned him about the events of the previous days, he had no memory of our conversations or his demonstration of impossible knowledge. He remembered collapsing at work and waking up in the hospital, but everything in between was gone. Medical tests showed that Marcus had returned to completely normal neurological function. His EEG patterns were now typical for a healthy adult, and he showed no signs of the enhanced consciousness he had displayed for 3 days. It was as if whatever connection he had maintained to his near-death state had finally been severed, leaving him with no memory of his extraordinary abilities. I discharged Marcus home with follow-up appointments in cardiology and neurology, but his test results remained normal and he experienced no recurrence of cardiac problems. When I saw him 6 weeks later for a final checkup, he was back to work and living a completely normal life with no memory of the remarkable things he had known during his hospital stay. But Marcus's case had a profound and lasting effect on me. I found myself questioning every assumption I had made about consciousness, death, and the nature of human experience. If Marcus could gain access to information while clinically dead, what did that say about the nature of consciousness? If his awareness could transcend the boundaries of his physical body, what did that mean for our understanding of life and death? I began researching similar cases and discovered that Marcus's experience, while rare, was not unique. There were documented cases of near-death patients demonstrating knowledge they couldn't possibly possess, though few were as dramatic or well-documented as I had witnessed. The medical literature contained reports of patients who accurately described events that occurred while they were unconscious, but these cases were often dismissed as coincidence or faulty memory. What disturbed me most was the realization that mainstream medicine had no framework for understanding or investigating these phenomena. We are trained to focus on measurable, reproducible results, and Marcus's case defied both criteria. I couldn't replicate his experience, and I couldn't measure the mechanism by which he had gained his impossible knowledge. 3 months after Marcus's case, I was treating another cardiac arrest patient when I found myself hesitating during the resuscitation. Instead of focusing entirely on the medical procedures, I was wondering whether the patient's consciousness was somehow still present, observing everything we were doing. I began to question whether our understanding of death as a definitive endpoint was accurate, or whether it was simply a transition to a different state of awareness. This uncertainty began to affect my clinical decision-making. I started second-guessing my pronouncements of death, spending excessive time with families trying to explain concepts I didn't understand myself, and experiencing anxiety about cases that should have been routine. I realized that Marcus Williams had fundamentally changed how I perceived my role as a physician and my understanding of the patients I treated. The final straw came 6 months later when I was called to pronounce death on an elderly woman who had died peacefully in her sleep. As I completed the examination and prepared to sign the death certificate, I found myself wondering whether she was still aware, still present in some way that our medical instruments couldn't detect. The uncertainty was overwhelming, and I realized that I could no longer practice emergency medicine with the confidence and decisiveness that the specialty requires. I submitted my resignation from St. Catherine's Medical Center 8 months after Marcus Williams walked back from death and changed everything I thought I knew about consciousness and mortality. In my resignation letter, I cited personal reasons and a desire to explore other career opportunities, but the truth was that one patient's impossible experience had shattered my scientific worldview and left me unable to practice medicine with the certainty that effective patient care demands. I now work as a medical consultant for pharmaceutical companies, reviewing drug trials and safety data. It's work that allows me to contribute to medicine without making life and death decisions about patients whose consciousness might extend far beyond what our current understanding can measure or explain. I still think about Marcus Williams regularly, wondering whether his experience represents a glimpse into a reality that exists beyond our current scientific understanding, or whether it was simply an extraordinary neurological anomaly that defied explanation. I've contacted him several times over the past year, but he maintains no memory of his remarkable abilities and seems genuinely puzzled by my questions about his hospital stay. The case of Marcus Williams remains the most unexplained and transformative experience of my medical career. It taught me that medicine, for all its advances and sophistication, still encounters phenomena that challenge our most fundamental assumptions about consciousness, death, and the nature of human experience. It reminded me that the boundary between life and death might be far more complex and permeable than we currently understand. Most importantly, Marcus's case forced me to confront the possibility that some patients who appear to be unconscious or dead might be experiencing forms of awareness that our current medical knowledge cannot detect or measure. It raised profound questions about end-of-life care, about how we communicate around unconscious patients, and about whether death is truly the final endpoint we believe it to be. The medical community continues to struggle with cases like Marcus's because they don't fit into our evidence-based framework for understanding disease and treatment. But perhaps that's exactly why these cases are so important. They remind us that human consciousness and the nature of life itself remain profound mysteries that science has not yet solved. For now, Marcus Williams lives a normal life with no memory of the 23 minutes he spent dead or the 3 days he spent demonstrating impossible knowledge. But somewhere in the files of St. Catherine's Medical Center, his case remains documented as a reminder that medicine still has much to learn about the most fundamental questions of human existence. And sometimes, late at night when I'm reviewing pharmaceutical data and remembering my days in the emergency room, I wonder whether Marcus was right about consciousness persisting beyond death. I wonder whether the patients I pronounced dead over the years were still somehow present, still aware, still listening to everything we said and did in those final moments. If that's true, then maybe death isn't the ending we think it is. Maybe it's just another state of consciousness, one that occasionally allows someone like Marcus Williams to return with knowledge that shouldn't exist and memories that challenge everything we think we know about the nature of human experience. The case will always remain, for me, the most compelling evidence that consciousness might be far more than just brain activity, and that death might not be the absolute boundary between existence and non-existence that medical science assumes it to be. In a profession built on certainty and evidence-based decision-making, Marcus Williams taught me that some of the most important truths might lie just beyond the reach of our current understanding.